Thank you so much. Thank you for having me here today. It's wonderful to be here with you who are all kindred spirits who love caring for older adults as I do. I have the privilege of being a geriatrician at Vanderbilt in the Nashville VA and currently serve as the Associate Medical Director and Attending Physician at Woodcrest at Blakeford Post-Acute and Long-Term Care setting, where I too strive to create a culture of continuous improvement and choose to do that for the sake of our residents that we so love. It's wonderful to join you today to discuss a topic of great importance to us all in this field. So I would like to impart with you ways to don't fall for that, a multidisciplinary approach to fall prevention, assessment, and intervention for the care of older adults. So our objectives for today are to discuss the impact of falls in the post-acute and long-term care setting, to recognize modifiable risk factors, including intrinsic and extrinsic risk factors, to think through a case study together of a resident with a fall with injury, discuss a systematic approach to fall prevention as well as post-fall assessments using a mini root cause analysis, and consider interventions that each member of the care team can act on to address common factors associated with falling that can be communicated through care planning. I have no financial interest to disclose, but before we jump in, I'd really love to just get to know each other a little bit. I know it's been a long day and you guys have been listening to a lot of people talk, so I think it's really important before we get into a clinical talk or talk about quality to really think through why we do what we do and make sure that we set the tone for the fact that this is not just about the science, it's about the people. All our events can be modifiable, but they impact people that we love and that we know and we care for. So I'd like to just tell you a little bit about how I became interested in geriatrics and developed a love for caring for those in the nursing home. And I'd love to hear from some of you if you're willing to share. I was written by a lady that I went to church with who asked me if I would come and sing for her mom who is about to pass away. I used to sing in church a lot when I was little. I was about probably 10 when this happened, and so of course I went and did that for Miss Chatham, and I was really shy. I still am, but I felt called to do that. And when I went, I was blown away by how comfortable I felt. I found that I really connected with the older adults and felt safe there because mostly they wanted someone to listen rather than talk, and I could hold their hands and listen to them. And so that's how I became interested in nursing home care, because these are patients who are often overlooked, who are underappreciated in our society, and I'm so pleased to be here with all of you who understand that drive to care for those and to not overlook them. So would anyone like to share what drove you to nursing home care? You look like a willing participant. Yeah, how about you?
Can you hear me? I'm used to talking. So I got in, and I'm actually the CMS QIO, so I'm not even in long-term care anymore, but my background, my history, I'm a physical therapy assistant, and the reason I went with long-term care, because you know there's a lot of places I could have ended up, was I was raised by a single mother who was a nurse at a nursing home, and our school, I'm really goosebumps, I don't get asked this question a lot anymore. My junior high and high school right across the street from where the nursing home was, and I was the one of the 6 kids that she had that would leave school and go directly to long-term care, hold their hands, build puzzles, read a book, do whatever. It just they were my people, and I had to get back. So that's how I ended up in that field.
That's so beautiful. Thank you for sharing. Thank you so much. Anybody else itching to say why they love geriatrics? Thank you for sharing that. I think we all have a story like that where we feel a unique connection to these people, and it's important that we set the tone for the fact that the days are long, but the impact that we can make is meaningful, and if we can prevent a single fall, we can actually provide that much longer of a meaningful quality of life for these residents. So let's start by thinking through what actually is a fall. It's important to lay the groundwork. So CMS considers a fall to be an unintentional change in position, coming to rest on the ground, floor, or onto the next lower surface. A fall may be witnessed or unwitnessed, and an intercepted fall occurs when the resident would have fallen if they had not caught themselves or had been intercepted by another person. So it's also important to distinguish what is not considered a fall. A fall is not the result of an overwhelming force, and it's also importantly not the result of an intrinsic physiologic event. So if syncope, for example, is witnessed, then that's not considered a fall because it is a major intrinsic event that caused that. So it's not a change in position due to stroke, seizure, or physiologic event. And also an anticipated loss of balance during intentional challenging by physical therapy, for example, is also not considered a fall. So let's also look at what is considered a post-fall injury by CMS. So no injury means that there was no evidence of injury noted on physical assessment, as well as no complaints of pain or injury after a fall, and no change in behavior. An injury, except major, is considered to be skin tears, abrasions, lacerations, hematomas, and sprains, or any fall-related injury that causes pain. A major injury, per CMS, is considered to be anything that includes a bone fracture, joint dislocation, or closed head injury with altered consciousness, or a subdural hematoma, of course. So what is the impact of falls in the post-acute and long-term care setting? We know from the CDC that the fall death rate in the United States has increased by 30% from 2005 to 2017. And falls are considered to be a geriatric syndrome. Every year, 1 in 3 older adults will fall, and 75% of nursing home residents will fall each year. And on average, they'll fall between 2 to 3 times annually. Now, fall-related injuries in and of themselves are not a common cause of death in older adults, but complications from falls are the leading cause of death from injury in adults greater than 65 years of age. So we know that falling is a significant cause of morbidity and mortality, especially among the frail elderly, and approximately 1,800 people will die every year due to falling in a nursing home setting. More than that, we know, though, that the quality of life can change dramatically from a fall, and this can be due to complications from functional decline, fear of falling, and deconditioning due to restricted mobility. So how many of you have experienced a loved one suffering a fall? Yeah, it's really scary. Has anyone helped you describe the language around falling and what it's like from the patient perspective? I'll start. So my mom's recently been having some falls, and I asked her to describe the experience for me. What was it like from her standpoint, of course, because we always think about it from a medical standpoint, and it's this quality metric that we so try to avoid. But what does it feel like from their perspective? And the answers that I got were that it seems like the beginning of the end. It's extremely scary. It feels like you're losing your independence, your mobility, your ability to function, your ability to live and do what you please. So this is an event that doesn't just cause harm to our metrics and to our facility, the quality that we're seeking to attain. It really impacts the life of a person who's falling. It's associated with functional decline and higher care needs, progressive loss of independence, and then that fear of falling that we've seen can really contribute to a cycle of deconditioning and recurrent falls, and so it feels like it's never ending. 60% of fallers report moderate activity restriction, and 15% report severe restriction in activity. And part of that is from the patient's own fear of falling, and then part of that is from us, because we want to restrict and prevent those falls, and so in some ways we're part of the problem when we're trying to restrict their mobility, which further causes deconditioning. And so there are ways to work on preventing falls that can still put a focus on the patient's own sense of independence and allow them to have some dignity and freedom. So falls are costly in every way for staff, administration, and most importantly, the resident, as we've discussed. The percentage of long-stay residents experiencing one or more falls with major injury is a long-stay quality measure used to calculate your star rating for your facility, published by CMS and Nursing Home Compare. And falls are also a major driver of emergency department utilization and hospital admissions, which are both short-stay and long-stay quality measures. And then, of course, falls and related injury are a major cause of litigation in the long-term care setting. But the good news is it is possible to significantly reduce the frequency of falls and the severity of fall-related injuries through prevention and targeted intervention. Preventing falls does constitute a significant challenge in nearly every healthcare setting, but I would say even more so in the post-acute and long-term care setting, because there is a multifactorial etiology to each fall event, and the use of each member of the interdisciplinary care team is critical to targeted intervention. So let's think through some of the risk factors for falls, especially when we're in a facility where nearly everyone is at risk for falls. It's important to delineate those risk factors and understand how you can tailor your prevention strategies. So the strongest single predictor of a future fall is a history of falls. It's important to record recent fall in the problem list of a patient with a fall within the last 6 months. And most falls in the post-acute and long-term care setting are going to be anticipated physiologic falls rather than accidental traumatic falls. So it's important to document the risk factors that you identify in the resident's record and tailor care planning and interventions to mitigate that fall risk, and then communicate that risk at every change of shift and inform all staff who encounter the patient about the need for frequent rounding. So falls are often the result of a complex interaction of intrinsic, extrinsic, and mediating factors. Intrinsic factors can lead to falls, extrinsic factors alone can lead to falls, but together they can create a vicious cycle that leads to mediating risk factors that can also lead to falls. So let's look through some of these intrinsic risk factors. And again, these are modifiable, but our work is certainly cut out for us. Multiple factors can be involved in any given resident. For example, a previous fall may generate that fear of falling, which we've discussed, which results in reduced mobility and leads to deconditioning. An acute illness, such as pneumonia or urinary tract infection, may cause weakness, dizziness, or deconditioning. Medications that have central nervous system effects can also place patients at increased risk for falls, especially within 3 days of a change in a central nervous system active medication. In addition, several comorbid conditions may be associated with falls. Musculoskeletal problems can impair strength and biomechanics, as can stroke, Parkinson's disease, or other neurological diseases. Peripheral and autonomic neuropathies, commonly seen in diabetics, can impair position sense and sense of proprioception. Patients on cardiac medications for heart failure, hypertension, and arrhythmia can have anticipated side effects of low blood pressure or low heart rate that can increase the risk of falls. And then visual, hearing, and sensory impairments can make one have decreased awareness to their surroundings. And finally, the resident's cognitive status, lack of awareness of safety measures, and impulsivity and limited insight and judgment regarding their own limitations can also play a role in fall risk. But so many intrinsic risk factors mean that there are lots of opportunities for us to mitigate risk, and there's a role for everyone to play. So risk factors for falls are known to be cumulative, and the risk of falling goes up stepwise with each additional risk factor. There's a landmark publication by geriatrician and falls researcher Dr. Mary Tinetti, who published that in a cohort of community-dwelling adults over 65, 8% will have a risk of falling within any given year if they have no risk factors at all. But with each additional risk factor added, there's an increased risk of falls, such that with 4 or more intrinsic risk factors, the risk of falling is 78% in any given 12-month period. So it can be inferred that by mitigating even one risk factor involved in this complex interaction, the risk of falling can be reduced. Looking through extrinsic risk factors for falls, many patients are at a higher risk for falls or significant injury from falls within the first several days of admission. You know that that's a very vulnerable period for these patients when hospital-associated delirium perhaps can actually increase the risk of falling sixfold. Environmental factors can be low-hanging fruit, such as slippery surfaces, poor lighting, cords, clutter, obstacles, and items placed out of reach can all contribute to falls. Inappropriate footwear is an easily modifiable risk factor. We know what ideal footwear needs to look like for older adults, and it's important to make sure that they have the appropriate slipper socks when in bed. Bifocal or multifocal lens can actually increase the fall risk due to skewed depth perception, yet we still see so many of our patients with those eyeglasses prescribed. And use of assistive devices that are not appropriately tailored to the cognitive or functional needs of our patients can also contribute to falls. So it's important to make sure that the assistive device is the correct one. I think we've all probably seen the rollator that got away from one of our patients, so make sure that we're not overlooking that as an extrinsic risk factor. And then, of course, we've all struggled with direct care workforce shortages, and we know that that can play a role when unfamiliar staff can be a trigger to persons living with dementia. And perhaps temporary staff who are well-intended may be less attuned to the particular risks and needs of a patient with some degree of cognitive impairment. And that can also be an extrinsic risk factor to increase the risk of falls.
What do you do about the walking illnesses if that's what they need?
Well, you're right. That's I've seen that so often. Occasionally, if I've identified that I think that that's contributing, that their vision and depth perception is a major contributing risk factor, then I would actually send them back to optometry or ophthalmology to perhaps to identify another option. But it is so commonly seen, and I wonder why our ophthalmology and optometry colleagues still continue to use that so frequently. But I'm sure they're well-meaning. But that's just one of the many reasons that falls can be increased in this setting. So it's important to use a systematic approach when we're looking through fall prevention strategies. And so we think of this as having multiple lines of defense. First, we want to institute universal precautions, which just includes familiarizing the resident with the environment, having them demonstrate call light use, making sure it's within reach, and keeping patient areas free of clutter. But then we use a risk factor assessment upon admission where our nursing staff provides standardized fall risk factor assessments. It doesn't really matter which tool is used, whether it's Morse or Stratify, and the overall risk score is less important than identifying the contributing factors which lead to increased risk. So identifying whether it's mental status or history of falls that's really causing the score to go up is very critical, so that then we can tailor prevention strategies to the specific findings of the assessment and use care conferences to ensure risk factors are sufficiently addressed and strategies are documented. So if there's a history of falls, we need to understand what were the circumstances surrounding the previous fall and how can that now be avoided. If it's mental status changes, can we perform non-pharmacologic delirium precautions, maybe start melatonin in the evening to mitigate delirium. And if it's urinary incontinence, then we need to identify that proactive toileting should be prioritized. So we all have a role in mitigating fall risk among residents, and it takes the whole team. Nursing is critical for that fall risk assessment on admission, communicating the concerns to the provider, and ensuring adequate hydration, nutrition is available to the patient, and delivering that person-centered care. Nurses are the ones who are getting to know the residents and can understand the nuances that are necessary to tailor the prevention strategy to the specific patient. Our CNAs are very important in our prompted toileting schedules, notifying staff of transfer needs or acute changes in mental status, and placing needed items within the resident's reach. Housekeeping is critical for notifying staff of environmental hazards. The provider can be called on to perform a comprehensive geriatric assessment, including a thorough fall history and functional status assessment. And then a medication review to to reduce potentially inappropriate medications, as well as our pharmacy colleagues who can do the same. Physical therapy will help evaluate the needs for the appropriate assistive device, and of course lead the efforts through rehabilitation and exercise regimens, and address balance and gait impairment. And administration is important for supporting our staffing needs in the front line to ensure that there are safe resident-staff ratios and that the building design is appropriate for reducing environmental risk factors. It's important that we all work together to create a culture that prioritizes fall prevention in service to our residents. So taking a multidisciplinary approach, it's important that we establish a systematic approach to resident safety that complies with CMS regulations. It's recommended by the Agency for Healthcare Research and Quality that you have a separate falls committee to serve as an implementation team on the ground and have direct care champions from various disciplines to lead training and education efforts on best practices system-wide, and obtain buy-in from key stakeholders. And that includes your frontline workers, administrators, and patient and family representatives to enhance the culture of continuous improvement. It's not a sprint, it's a marathon, and the process of improving and protecting patients from falls is ongoing. It's important to integrate fall prevention into the existing workflow, and that can really easily be done through putting a priority on purposeful rounding. This committee could potentially conduct environmental surveillance and perform gimbal walks, for example, and define the target goal and audit outcome measures. AHRQ suggests using previous median fall rates, the national standard, or set a reach goal of lower than the national standard as your potential outcome measure. And I also recommend separating data for post-acute versus ICF versus memory care units, as these populations are likely to differ substantially in fall rates. So falls among residents represent a unique opportunity for the interdisciplinary team to utilize individual and systems level data to pursue a culture of safety and quality improvement. And efforts should also focus on minimizing the fall risk and risk of fall-related serious injury, but also maximizing individual dignity, freedom, and quality of life for our residents. So if you're thinking through using data to drive quality improvement, you want to look at your systems level baseline data first to determine your median fall rate and monitor success of ongoing prevention processes. So you can further delineate the data trends and analyze when falls are occurring. Identify whether they're occurring at a specific time of day, at shift change, with employed or temporary staff. Does it revolve around toileting? So that could be a potential for intervention. And so you can start by calculating the median fall rate. So if you're looking at the data monthly, it's pretty easy to think through occupied bed days. So if you have a 30-bed unit for 30 days and each bed is filled for all 30 days, the denominator is 30 times 30, which is 900. If you have 3 falls within that month time period, you can say 3 divided by 900 and then multiply that times 1,000 to get your 1,000 occupied bed days. And so your median fall rate, that red line there on the run chart, could be around 3.3 falls per 1,000 occupied bed days. And so then you can fairly easily, using even Excel, create a run chart where you look at each month's data to see how you're doing. So you want to have a baseline before you start your interventions, and then at any point along the time period, document when you're using those small cyclical tests of change to reduce the fall rate. And you want to do one thing at a time if possible, so you can really track how much impact that's having on your fall rate and what that trend is looking like, and then monitor for effectiveness and modify the interventions when necessary. Some may not work, some may have a huge impact, and then despite your efforts, sometimes the trends may not change, and that's why it's important to also look at individual level data, because you may have individuals who just have extreme impulsivity and exhibit unsafe behaviors, and that can skew some of your data. So you want to look at this individual level data from incident reports to really get an idea of how we can target our highest risk residents to tailor interventions accordingly. Use close calls as learning opportunities and communicate and document modifications to the fall prevention strategies and care conferences after each subsequent fall. So let's move into a case study of Mrs. B. And I know you've all seen Mrs. B before. She's an 87-year-old female admitted to your facility with a history of Alzheimer's disease for approximately the last 5 years, who's been cared for by her loving husband and daughter at home up until this point. But over the past several months, her agitation and insomnia has made it impossible for her loved ones to care for her safely in their home. She was recently hospitalized for a fall and found to have a UTI and has since completed treatment. Past medical history includes diabetes with peripheral neuropathy, history of TIAs, hypertension, osteoarthritis, depression, urinary incontinence, macular degeneration, and a history of falls. This sounds like a lot of our residents, right? Very complex medical history and social history. She's a retired teacher, loving wife and mother, Christian, non-smoker, and she's on several cardiac medications, including metoprolol, losartan, aspirin. She's on linagliptin for her diabetes, Celexa, gabapentin, and Seroquel. So what are you initially worried about with this resident? Can anyone identify any intrinsic or extrinsic risk factors that you're noticing right off the bat? Absolutely. Psychotropic meds. She's on Celexa 20 and Seroquel 25. And our colleague Marty can help us do some gradual dose reduction on those. He works with me at Woodcrest. Any extrinsic risk factors you're noticing? It's hard to say when you don't have a picture of where she is, but let's think through the fact that she was recently admitted to the hospital. And so that's an extrinsic risk factor, is that recent admission. And we know that in the first several days after an admission from a hospitalization, folks are at an increased risk of falling. Anything else? Absolutely. Macular degeneration is going to lead to likely some low vision and increased sensory deficits, which will increase her risk of falls substantially. Also, she had a history of falls at home. So we know that history of falling is the strongest single predictor of a future fall. Also, she's unfamiliar to the staff. This is a new environment for her, and she's a person living with dementia. So that's a big extrinsic risk factor. Additionally, she's likely to exhibit, based on her history, some unsafe behavior. She has some impulsivity, worsening agitation, insomnia. She may try to stand, transfer, or walk alone unsafely. She may try to climb over bed rails or get out of bed alone unsafely. She is a diabetic. She's only on an oral medication, but there still could be a risk of hypoglycemia or hyperglycemia from her diabetes. She likely has a loss of sensation in her feet due to diabetic neuropathy, which could alter her sense of position. She has urinary incontinence and a recent UTI, which could lead her to try to get up to toilet by herself. She could have postural hypotension as a result of the cardiac medications that she's on. And there could even be a systemic illness involved as the underlying etiology of some of the worsening agitation and insomnia. So there are a lot of things going on with this resident that are going to put her at a tremendous increased risk of falls. What prevention strategies could you think through for this resident? Let's start with the environmental and equipment strategies. So of course, low-hanging fruit, reduce clutter, keep clear pathways, especially given her vision impairment that you mentioned, provide adequate lighting at night, add labels and pictures to help her locate the bathroom and orient her to her room, provide frequent reassurance and orientation to the facility. As far as gait and mobility, she definitely needs an evaluation by OT and PT. Screen her ability to transfer and ambulate safely to determine the appropriate level of staff assistance needed. And then medications. You can ask the provider to review medications and their possible interactions and side effects, Ask the consultant pharmacist to review medications. You can also implement sleep hygiene measures, no caffeine after 4 p.m., limit daytime napping, provide comfort measures at bedtime, offer a food or snack, and begin an individualized toileting program at night that's in tune with what her particular sleep patterns are, when she awakens throughout the night, so that you can be available for proactive toileting during those time periods when she's awake. I think this is the trickiest part, when patients have anxiety, agitation, and unsafe behavior or impulsivity. It's important that we think through implementing general behavior management strategies, getting to know our residents, getting that human connection with them, what they like and dislike, so that we can be attuned to their needs, even if they're not able to verbalize them to us. Leave the door open at night for regular checking by staff. Provide frequent reminders about using the call bell. Conduct trial use of a change in position. Use a low bed and mat. And learn about her culture, likes, dislikes, religious preferences, so that you are able to provide 3 things that can bring her comfort in this new environment to help facilitate the transition to your facility. Also, pain management is important, especially in our residents with dementia who may not be able to express their pain. It's important to have some degree of pain control available to them. Consider scheduling something for them, like Tylenol or something that's safe for them, lidocaine patches, things of that nature that can help mitigate pain for patients who may not be able to fully express it. So Mrs. B has been at your facility for 3 days and has only slept 3 hours per night. This sounds pretty common. She's restless, anxious, and often cries out for her husband. She constantly wants to get up from her chair or bed. Late one night, Mrs. B was found on the floor between her bed and bathroom door. Her undergarments were soiled, and she continued to cry out for her husband. She had 2 noticeable skin tears to her forearm and bruising to lower extremities. What are some immediate interventions that you would institute for this resident? So they're already up there. So we would complete an assessment of the resident's condition using a really thorough head-to-toe examination. So that includes looking for musculoskeletal injuries, head and neck injuries, skin changes, mental status changes, and changes in level of consciousness. It's also important to obtain and monitor the following and make sure that staff is educated about the proper ways to document neurologic checks, since the resident was found on the floor unwitnessed. Also, looking at postural or orthostatic vital signs. If the patient is limited because of a potential injury, you can do only lying to sitting as a possibility to check those vital signs to see if there's any orthostasis that may have contributed to the fall, especially since she's on cardiovascular medications for hypertension and has a history of frequent falls documented. Additionally, you want to get a blood glucose level in this patient since she has a known diagnosis of diabetes. Through your thorough head-to-toe examination, it was noted that she had a left hip fracture and was sent to the hospital via EMS for evaluation after family was notified. So falls with major injury in a facility warrant a formalized root cause analysis in addition to the standardized incident documentation and post-falls assessment. And I think that's really important so that we can identify all of the various factors and systems level issues that are at play. When you're looking at a root cause analysis, you're looking at processes, not people. So we're never playing a blame game. We're identifying what processes maybe went awry, or maybe they didn't. Maybe this was unavoidable, but there are ways to modify and help reduce the frequency and severity of fall-related injuries. So because falls can be more complex than they first appear, it's important to map out the sequence of events that led to a particular fall with major injury specifically, and uncover root causes and associated performance gaps. So by using root cause analysis after a fall, we have a powerful systems analysis tool that informs performance improvement and drives purposeful change to prevent harm. With a focus on organization-wide systems improvements, it also operationalizes stronger care and service delivery processes, which help to ensure better financial sustainability. Beyond offering a tool for mitigating harm alone, an RCA helps fulfill federal quality assurance and performance improvement requirements for skilled nursing facilities and similar state requirements that are increasingly present for other settings on the aging service continuum. So that includes assisted living, home health, hospice, and PACE programs. Using a systems thinking approach to the RCA process acknowledges the importance of organizational culture, which is what we're really trying to change, and puts that focus on our facility being a culture of safety over individual blame, which we never want to do, and it enhances resiliency and the effectiveness of preventing adverse incidents from occurring. Those responsible for conducting RCA should always keep in mind identification of root causes is not the ultimate outcome, but rather it's the means to a different end to create sustainable performance improvement to address those. So once identified, staff can address root causes through purposeful change and organizational development. So the four main steps in root cause analysis that we could perform after a fall with major injury include first just getting an understanding of what happened around the initial event, creating flow diagrams to understand the sequence of events that led up to the fall with major injury. And we can also gather resources to fill in that flow diagram through conducting interviews, reviewing literature, and asking triage questions to help get to the why of the event that happened. Then we want to collate the final understanding of the event by creating a cause and effect diagram. So we start with the various causes that we've identified and ultimately lead up to the effect, which was the fall with major injury. And then formulate root cause statements, which again focus on processes, not people, and identify the contributing factors that led to the fall. It's important to have an action plan for each identified root cause statement that includes a person who is going to be accountable for making sure that that root cause is addressed and include a time frame for completion. So these are some examples of interventions for Mrs. B that we can think through once she returns from the facility to the facility from the hospital. And as you can see, this is an example of what sort of things you can include in your care conferences and communicate to families and patients and other staff members about risk factors that are noted, actions that are going to be taken, and persons who are going to be accountable for making sure that these root causes are actually addressed. So this patient, upon returning from the hospital, is likely to continue to have behavioral disturbances and impulsivity. And so it's important for nursing staff to identify her comfort preferences and include in the handoff the ways that she has noticed the ability to reduce agitation and improve the ability for unfamiliar staff to redirect those behaviors. Purposeful rounding should also be prioritized to address toileting, pain, comfort needs, and position at least every hour for this high-risk patient who's just returned to your facility after having a fall with major injury. Also, urinary urgency can be addressed by implementing a prompted toileting schedule every 2 hours, and during the night shift, understanding when her awakening periods are so that she can be toileted during that time period so as to not interrupt her sleep when she's able to get some sleep. And our CNAs really provide accountability for that. Unsteady gait, which this patient has exhibited, it's important to have PT, OT reassess the patient upon return from the hospital and make sure she has the most appropriate assistive device. This patient's dementia is likely too far advanced for a rollator, for example, and we might need skilled therapy services upon completion. And after skilled therapy services have completed, we'll need to implement a restorative nursing exercise plan for that patient's maintenance of their functional status. Thinking through footwear, which as we've discussed is an easily modifiable risk factor. The nurse and family can help to check footwear for a secure fit, non-slip sole, make sure that there's no trailing laces, and we can ask relatives to supply a safer replacement option if we think that that's a contributing factor, and make sure that nursing staff is aware of the importance of slipper socks while in bed. In a patient who's unable to use the call bell to report needs, consider talking with your director of nursing, potentially move them to a room that's closer to the nurse's station when one becomes available, and consider alternatives to a call bell, such as brass bell or moving the bed inside or earshot of the nurse's station. And then looking at things like bed height, which all team members have an accountability to ensuring that the bed is at the lowest possible height, unless this would reduce mobility or independence. All right. So in summary, it is possible to significantly reduce the frequency as well as the severity of fall-related injuries, prevention, and targeted intervention. Falls are often the result of a complex interaction of intrinsic, extrinsic, and mediating factors, but every little bit that we can reduce or intervene upon decreases the risk of that patient falling and decreases the risk of them having substantial harm to their quality of life, dignity, and independence. Because falls can be more complex when they first appear, it's important to map out a sequence of events prior to and after the event to help uncover root causes and identify associated performance gaps. And then multidisciplinary intervention guided by post-fall assessments or formal RCA processes can be addressed during care planning to reduce the recurrence of falls. It's important, lastly, to remember the why, to remember why we're in this line of work, because we're people who wish to honor and cherish our older adults, and preventing falls is a really important way to make sure that patients are able to continue to live to the best of their ability with an appropriate quality of life and continue to maintain their function and mobility, because that's usually what matters most to them, and we want to honor and cherish that. And so any little bit that we can do to prevent falls in our facility or address falls and tailor intervention strategies once a fall has occurred to prevent another fall is going to be something that is incredibly meaningful in the life of that resident, and that's what we're here for. Thank you so much for your time and attention. It was wonderful to be here with you today, and I'm happy to take any questions that you have. Any questions? I'm sure I have a lot to learn from each of you who have a lot more experience than I do in facilities, and I have really enjoyed working at Woodcrest at Blakeford and learning from all my colleagues across disciplines, because we all have a lot to learn from each other, and only in working together can we truly prevent harms to our older adults. So.